Hello and welcome. We are so excited to have you here today. We have an action-packed hour of education for you. Our program today is called Uncovering Deviations from the Standard of Care, and I am your host. And as you know, Pat Iyer will be the one that is responding to the variety of questions. And certainly if you have questions for us, please hold those till the time that we ask for your questions, and we hope to be able to respond to those. Would you like to get shortcuts for evaluating the standard of care? Join us, as you are now, as we are going to discuss this topic. My colleague Pat Iyer is a very experienced legal nurse consultant, and she has reviewed hundreds of cases as a medical surgical nursing expert, and she's written more books on legal nursing than anyone else in the world. She is the host of the Legal Nurse podcast, now in its 9th year, and this reaches listeners in 107 countries. When Pat is not talking, she is enjoying crime novels with courtroom dramas. Today, we are going to emphasize the importance of understanding how to uncover deviations from the standard of care and how this can impact liability in legal cases. So welcome. Pat, to start, can you explain what the standard of care means in a medical legal context? How do we define it? And who determines what the standard of care is?
Yeah, that's a great question, Barbara. And it's something that puzzles many, particularly inexperienced legal nurse consultants when they get a nursing malpractice case to review. The legal standard is that it's what the reasonably prudent person would do in similar circumstances. And in that case, we are talking about a person with the same education, training. The question comes in as we are evaluating cases is that we tend as legal nurse consultants to be highly critical, and we evaluate cases sometimes with the idea of perfection. It's not what the best, most experienced, seasoned, intuitive nurse would do in that situation. It's the reasonably prudent person. So there's some room for negotiation and manipulation and thinking about what is necessary when presented with that situation. It's also a national standard of care, but with a footnote. So we've got professional associations who present their standards of practice. We have nurse practice acts. We have textbooks, and we've got nursing literature that defines for nurses in the country what is the standard of care. But it's also unfair to hold a tiny rural hospital to the same standard of care as a large tertiary facility where there are interns and residents and people available 24 hours a day. If you live in the Eastern time zone, as about 50% of our population of the United States lives in the Eastern time zone, and you live in a major metropolitan area, you may never have the experience of working in a tiny rural hospital where there might be a 5-bed emergency department and maybe 50 beds for patients to be admitted to. So we look at a national standard, but we also take into account that if that tiny hospital needed to mobilize the helicopter transport to take that patient out of the emergency department to a major hospital, it's going to take some time to get that person to the level of care that they need. We do expect facilities who are writing policies to adhere to those national standards. If they write a standard, let's say they write, as an extreme example, a standard that says that nurses should change their patients every 8 hours, turn and reposition every 8 hours, and the national standard is every 2, that hospital policy can't be used to say, oh, well, look, it's only every 8 hours. because we know that appropriate nursing care is more frequent turning and repositioning than every 8 hours.
Thank you. As you know, I serve as a nursing expert in court, and I want you to address how do legal nurse consultants evaluate whether the standard of care was met in the medical records? What are the key indicators that they should look for?
Well, first of all, it's critical that you have a full, complete medical record. If you are working with inexperienced medical malpractice attorneys, they may think that they can give you an abstract, which is just portions of the medical record. You need the full, complete record to be able to evaluate. That doesn't mean that you have to look at every single page, but at a minimum, you have to have the record to be able to look at the physician orders and the nurse's notes and the assessments and the therapy notes. There are often pieces that are hidden in a medical record that shed light on what happened. As an example, there was a man whose case I evaluated as an expert who had surgery on his neck. He had a cervical discectomy and a fusion. And the first day post-op, the physical therapy department used 3 people to get him out of bed. He was a big guy, over 6 foot, 250 pounds. In the afternoon, a tiny nurse's aide came in with a walker and said, "I'm going to get you out of bed." And he said, "It took 3 people this morning. I don't think you're going to be strong enough to do this. Trust me." You know, the famous "trust me" phrase, "I can do it." She got him up. He stood up. He immediately lost his balance and fell to the floor. And in hindsight, what we think happened is that he injured his neck where he'd had the surgery the day before. Over the course of the evening time, he started developing numbness and tingling and lack of motor sensation. Barbara, as the orthopedic nurse, is going, "Warning, warning." And the night nurse called the neurosurgeon and said that he was anxious. Well, she didn't say why he was anxious. The doctor ordered a sedative to calm down his anxiety. He was anxious because he had lost motor and sensation up to about his nipple line. And then a few hours later, the neurosurgeon comes in and says, "What's going on here?" Orders a CAT scan, takes him back to surgery. Damage is done. Spinal cord is gone. The theory was that that jarred the surgery and damaged the cord. Now, the reason I bring this up is that the nurse taking care of the patient, that shift, the RN, when the fall occurred, wrote nothing in the nurse's notes about the incident. She did not notify the physician. There was no incident report filled out. We knew it happened because there was a student who was a physical therapy student who documented in the physical therapy notes that the patient fell when being assisted out of bed. That was the only way that we were able to document that there was an incident. In addition, however, he had roommates. He had another man and his wife who were in the room at the time of the fall, and they wrote up a statement for the attorney describing what they saw and heard when this guy hit the floor. So that bystander statement was critical, both from the patient and from the wife, who were completely alert and coherent and could describe in detail what occurred. So you're looking at the important parts of the medical record, and you're digging into and using your analytical skills to examine those parts of the record, to think about the deviations that made a difference. And I do want to stress that not everything that goes wrong makes a difference. You could have an IV that stayed in for 24 hours longer than it should have, but did not cause thrombophlebitis and did not cause any incident for this person. Maybe it's a deviation from the policy to change the IV site. but it didn't have any outcome. You could have, as I saw a report done by a long-term care nursing expert, she put in her report every time the nurses did not give Tylenol for a temperature of over 101. That wasn't the issue in the case. There was no allegation that the nurses failed to intervene or report signs of an infection. It was an entirely different issue. Yes, it was a deviation. Yes, the nurses should have given Tylenol, but it had no bearing on what happened to this person. And also keep in mind that you could have a beautifully documented medical record. I got involved going to Brooklyn one day to testify in a case involving a woman who was in the hospital who developed a stage 4 left hip ulcer, stage 4 right hip ulcer, and stage 4 heel ulcers. She had absolutely beautifully documented flow sheets that showed that the nurses changed this person's position every 2 hours. What made me suspicious was it was documented as 1, 3, 5, 7, 9, 11, 1, 3, 5, 7, 9, 11. For weeks, there was never any alteration in the time. It was never 1:15. It was never 2:10. It was every 2 hours. Well, how did she end up with stage 4 pressure injuries as if the nurses were indeed providing the care that they documented? So you've got to apply some common sense when you look at the records and think about, could this outcome have occurred if the nurses delivered the care that they said that they documented? Or did they just provide a perfect chart, but it had no bearing in reality? Or did they copy and paste from preceding shifts where you can pick up, this is the identical wording. I've read this once before. Or it's the same narrative entry that I've already read. The copying and pasting gets people in trouble all the time. So those are some key things to consider as you're looking at the medical record, looking at the key parts, using your nursing analytical skills to put this through an objective lens, knowing that you were hired because of your expertise in being able to evaluate medical records, and you understand far more than the attorney does.
You raised some excellent points, Pat. At this time, I'd like to ask everyone to put into your chat, what if an attorney were to ask you, what is the area in nursing where you have the most experience? What would you say? So if you could put that in the chat, we would appreciate it. And while our attendees are doing that, let me ask you, Pat, in your experience, what are some of the deviations from the standard of care that can be found in the medical records?
Yeah, that's a great question, Barbara, because there are some themes that come up for different clinical areas. And then there are also some generic issues. You are probably aware that the Joint Commission, now abbreviated TJC, by the way, if you're calling it JCO or JCAHO, you're way behind the times. So I still see that on some people's resumes. There are some key issues that we run into in healthcare, and the number one issue that keeps coming up over and over is inadequate communication, miscommunication, failures in communication. When you think about all of the factors that we handle, we have an incredibly complex system. Our healthcare system is filled with holes. I have told attorneys I envision a safety net under a hospital, and the safety net has got holes that you could drop a truck through. Miscommunication and communication issues are number one. Not following facility policies. They used to be in big binders in the nurses' station. They're now on computers in nurses' station. Nurses who are not familiar with caring for particular types of patients are required to become familiar, to look up what they should be doing. Do they do that? Often they don't, or they don't feel that they have time, or they don't realize what they don't know. I spent 7 years running a staff development department for a large urban hospital, and I was in charge of all the education for the nurses. And we had an expression: they don't know what they don't know, which is a chilling phrase. Medication administration errors are common in nursing cases, not following what we used to call the 5 rights. There's actually more, like 8 or 9 rights that are involved in from the time that that nurse gets involved in that medication administration to the time that they deliver the drug to the patient. Delays in calling for physician assistance is another huge issue. Being able to recognize that there's a change in the patient's condition and being insistent that that physician come. Barbara is well known at Mass General for recognizing complications and getting residents, shaking them by their putative shoulders over the phone and saying, you must come. There is a change in the patient's condition. You must come. And they listen to her because they know that she's got experience and she's concerned about the patient who's displaying this change. Not doing patient assessments or doing them incompletely is another whole issue that can result in allegations of deviations. Not changing the plan of care. See that all the time. A patient falls. Now the patient has a history of a fall. What are we doing differently as a result of that fall? Or not putting together adequate treatment plans.
What types of, oh, I'm sorry.
So those are the key, more generic, general things. And we'll look at your chat as we talk about some of the more specific areas.
Pat, what types of red flags should legal nurses be aware of when they're reviewing the medical records of potential deviations?
One of the big red flags is when a physician orders an antidote or a medication that has a potential agent to be able to reverse the effects of that drug. Sometimes the incorrect administration, for example, if a patient got too much heparin, sometimes that's not recorded in the medical record, but you will see an antidote for that overdose. Another is when you see X-ray reports that document fractures. I worked on a case of a man who was tipped out of a Hoyer lift, out of the sling in a nursing home. He fell and fractured both hips. The nursing assistants who were involved in that transfer were frightened to report it because they thought they would get in trouble. So they didn't tell a soul. And over the course of the day, he started showing these signs of fractures so that the next shift said, a lot of pain, a lot of crying, something's not right here, and ordered the x-rays that, or got the physician to order the x-rays that revealed the presence of fractures. Then the nurse confronted the aides who were involved in this. Then they fessed up and they said, what happened? So that's a red flag. When you see action being taken in response to an incident that's not documented, you then work your way backwards. 2 fractured hips. Okay, we know you can't fracture your hips laying in bed, so something had to have happened. If there's contradictory information, the physician says this, the nurse says that. I worked on a case involving a man who fell going down an escalator in a department store, and he fell into one of those metal holes that have the ropes attached to them, kind of old style, blocking off part of the store. And he had an intestinal rupture from this, was admitted to the hospital. The doctor was documenting abdomen soft, not tender, good bowel sounds. The nurses were documenting abdomen tense, rigid, no bowel sounds. This went on for 3 or 4 days. I did a nice timeline for the attorney showing what the doctor documented, directly below it for the same day, what the nurse documented to show the discrepancy. Or tampering with medical records. We know when in handwritten records, it's a little bit easier to pick up tampering. In electronic medical records, we know that audit trails can show people who've gone into the record and made changes. And it's a little bit more obvious when you're looking at an audit trail, but you may pick it up in looking at an electronic medical record. Or there's a description of an incident is another red flag, like I talked about with a man who fell, that should have been reported to the neurosurgeon, but was not followed up on. That's a red flag. When the physician came in the next morning and found his patient paralyzed from the nipple level down, you better believe that he was investigating what happened here. And he wrote in his progress notes that he was advised that there was a fall the previous day, but he was not notified at the time. That's a big finger pointing note.
Thank you. Moving forward, we are going to discuss if there's any particular areas of nursing that are more prone to lawsuits. And I'm looking here in the chat to see where what people's background is. And so I see that Krista Peterson is in labor and delivery. Lori Mullman is in the surgical ICU. Diane Honeygoski is in the ER. And let's see, Jane Shufro, PACU, and critical care. And those are just a few of the many responses that we've received. I know that Pat is going to address these further with more examples.
And we have an interesting variety of clinical areas represented here. You would not be surprised to know that most of the, or if we think about what are the common areas that are sued because of damages, that the highest risk is OB, labor and delivery, failure to monitor the laboring woman and not noticing changes in the fetal heart rate in response to the contractions is a big issue. Just yesterday, I recorded a podcast with Ashley Jefferson, who is a labor and delivery nurse, and we talked about Pitocin and how it is implicated in injuries to the fetus. So delayed responses to those changes are a concern. The fetus has the ability to compensate for a while, but then after a while runs through its reserve and then starts seeing the impact of the hypoxia that is going on during labor. Not acting on abnormal vital signs, either on the part of the fetus or the mother. I had an experience when I was a student that I will never forget. At that time, we had these big Dopplers that were basically a metal instrument that had a cord that you put in the ears, and you had to listen to fetal heart tones because there wasn't fetal monitoring at that point. And I got a heart rate from the fetus of 60. Why I remember this so vividly is that I went out to the nurse's station, and the OB for that woman was sitting on a chair, and on the lap of the OB was the head nurse, and they were cuddling. And I thought, well, this is interesting. I didn't realize this went on in the hospital. So I said to the nurse, I just got a heart rate of 60. Can you please come and check it? All right. Okay. Well, then as soon as the doctor and the nurse got in the room, there was immediate, okay, there's a problem here. I learned in nursing school, you got to report those, and I did. Anything that may happen in terms of vital signs for the mother can also be a warning sign, particularly postpartum when there's risks of bleeding or anesthesia errors. There's very high emotional and financial stakes for OB cases, catastrophic medical costs for infants. For the emergency department, failure to triage appropriately, that person who comes in with chest pain, who's trying to convince the nurses it's just gastritis, delays in care, not getting people into the treatment area fast enough. Hospitals really hate it when people die in the emergency department waiting room. Big investigation, big problems. Medication errors can occur. This is a high stress area with rapid turnover and long waits. We are seeing people and hearing stories about people waiting in the hallways of emergency departments for hours. And it's unpredictable. You've got emergency department nurses, and I know we've got some here, who have to be prepared to take care of somebody who could be carried through the door at a few days old to over 100 years old, and with a whole range of medical and surgical problems. This is an extremely diverse population. The staff have to be prepared to be able to intervene appropriately depending upon what's wrong with that person. I am Pat Iyer, and I wanted to tell you about a hands-on workshop that is coming up on June 5th, 2025. It's called Analyzing a Nursing Malpractice Case, a hands-on workshop. It gives you an opportunity to build case review skills that will help you keep clients and win repeat business. Attorneys need answers that they can use. They don't have time for a vague opinion or missed details. If you're not confident analyzing a case outside your clinical specialty, or if you're unsure where to start with the research, you're not alone. Many legal nurse consultants face the same challenges, especially with nursing malpractice cases. This hands-on workshop taking place June 5th, 2025, is designed to fix that. You'll work with experienced instructors, which are myself and Barbara Levin, to review a real case, identify the key issues, and learn how to find reliable sources that support your opinion. You'll know how to ask the right questions when an attorney first calls you so that you get the information you need right from the start. You'll also get some clear examples of how to tell if a case has merit before you spend hours going down the wrong path. Be sure to sign up for this June 5th, 2025 workshop by going to this link, lnc.tips/analyzing. That link will take you to the registration page so that you can get your seat and get locked in to participate in this hands-on experience. And if you see this podcast after the workshop has taken place, the recordings will be available for you at that link, lnc.tips/analyzing. We'll show you how to close the gap between your clinical background and strong analytical skills. I'd love to see you sign up for that workshop and spend the day with us to ramp up your skills on analyzing a nursing malpractice case. See you there. I'm Pat Iyer, and I've got a question for you. Is this you? I'm not sure how to tell if a nursing malpractice case has merit. If you answer yes to that question, you might be hesitant when an attorney asks you for a quick opinion, uncertain how to evaluate the medical records or what information you need to gather. In our June 5th, 2025 workshop, we will walk you through the entire process, from the initial phone call to identifying red flags and building a sound analysis. Or this could be you. I don't feel confident about citing standards of care or finding supportive literature. Knowing the case was substandard is one thing. Being able to support that opinion about the care with credible sources is another. In our workshop, you'll learn how to identify relevant standards, cite them appropriately, and strengthen your opinion with solid research. Or this could be you. I get confused about the difference between writing screening reports and expert reports. Whether you are a behind-the-scenes LNC or serving as a testifying expert, this workshop helps you understand how your role affects your report's wording and communication with attorneys. Go to this link, lnc.tips/analyzing, in order to sign up for our June 5th, 2025 workshop being taught by myself, Pat Iyer, and Barbara Levin, an experienced expert witness. If you see this podcast after that date, the recordings of our day will be available for you and you can learn from them. Be sure to go to the link, lnc.tips/analyzing, in order to get your seat for the workshop. I'll see you there. I'm Pat Iyer, bringing to you information about our June 5th, 2025 workshop. This is a day that we have set aside to help you learn how to more clearly and more efficiently evaluate a nursing malpractice case. With Barbara Levin and I at your side, you will have an opportunity to learn how to identify the 4 elements of malpractice and how standards of care will guide your analysis. We're going to cover the difference between being a behind-the-scenes consultant and an expert witness, and what type of information you should gather from the attorney-client during that first phone call that you get about the case. We'll talk with you through a set of medical records based on a real case so that you can determine the case merits and get hands-on experience looking at the elements of malpractice. You'll learn how to use research and literature to support your opinion. What sources should you be checking out based on the issues in these medical records? And you'll discover tips for presenting your findings clearly, whether you're screening the case or you're writing a full expert report. Barbara Levin and I are both experienced expert witnesses and will guide you based on our experiences in evaluating cases. Sign up for our June 5, 2025 workshop, Analyzing a Nursing Malpractice Case, by going to this link, lnc.tips/analyzing. You'll have an opportunity to join us for that full day. And if you see this podcast after the event is over, you can invest in the recordings and get the benefit of what we shared. The link again is lnc.tips/analyzing. I will see you there. Critical care issues. I know we've got some people who've put that in the chat. Improper monitoring, people who self-extubate, a big issue. Not notifying physicians of significant changes. And then, of course, there's lots of drips with many opportunities to titrate medication carefully and appropriately and evaluate responses based on the titration. If the nurses are not up on those drips, if they're not responding to the pumps, that can create catastrophic results. These are unstable patients. They need constant care. Med-surg units, Barbara and I have a background both in med-surg. We've looked at multiple cases involving falls and pressure injuries, not following up on abnormal lab results. It's our responsibility to report the hemoglobin and hematocrits that are reaching critical stages. Not giving medications appropriately. Many patients in Med-surg units reflect our population. They are elderly. They may answer to names that are not their names, but if you call them Bill, okay, maybe I'm Bill today. Checking ID bands and making sure you're accurately identifying that patient is critical. And these patients are often with multiple comorbidities. They may come in for one reason. They've got 3 other medical problems that are going on. There are med-surg nurses who are being overloaded with patients and they can't keep up with their assignments. And then often there is that dread change of shift. And when we say bad things happen to good people, the outgoing shift and the oncoming shift are preoccupied. People are putting their lights on. They're not getting help. They decide to get out of bed by themselves. You know what happens from there. And then long-term care, the 5th area after OB, ER, critical care, med-surg. Another high-risk area is geriatrics and long-term care, where we've got people who've got multiple risk factors. They've got the aging process, which puts them at risk. They are prone for falls, dehydration and malnutrition, medication errors, and pressure injuries. Often there is understaffing. The vast majority of the care, as you know, is delivered by certified nursing assistants who have varying levels of skill and attention to their patients, and floors that have licensed practical nurses with some RN staffing, but not the degree that exists in acute care.
Before we continue, Pat, could you discuss the workshop that's coming up on June 5th, during which time the attendees can get their hands on and get experience reviewing medical records? So I want everybody to pick up their pen and have a piece of paper handy.
Well, I've got some questions for you who are here, and this gets to the heart of what Barbara and I will be doing on June 5th during our day-long workshop, which is from 10 a.m. Eastern to 4:30 Eastern. We deliberately start our programs at 10 because we think that the people on the Pacific Coast can join us at 7 a.m. And I know 7 a.m. is early. We want to have you think about, if you've got a question in your mind as I ask you this, how do you tell that the nursing malpractice case has merit? If you're not sure about that, that's one of the ways that we are going to address that question through our workshop. It walks you through this workshop through the whole process from the time that the attorney contacts you about a case to the point that you identify some red flags and you analyze that case. Sometimes the answers are not obvious, and it requires us to go into the medical literature and find supporting information that will help you in analyzing that case. Are there seminal research articles? Is there key nursing literature? Is there an organization that offers standards of care that address this particular issue? I know, for example, Jane Shufro has a very strong background in post-anesthesia care unit. There's a nursing organization that issues standards specifically for that area to address the care that should be delivered in that area. And I'm sure that she has referred to those standards as she's written expert reports. And then there is a difference between screening cases and the type of report that you write in that instance versus when you are an expert witness and you're writing a report. Screening cases, you're behind the scenes. You might be working in-house as an employee, or you could be an independent LNC. You can put down in writing, in reports, a summary of what happened and suggestions for the attorney. And we'll go into how you prepare that type of report. That's not discoverable by the opposing counsel. When you are an expert, what you write down is discoverable. And sometimes new experts don't realize that. I have seen reports with comments in it that have been not something that the opposing counsel should have seen. We'll focus on the difference between those two kinds of reports. The first time I got a case as an expert in 1987, I had absolutely no idea how to write a report. I had never seen an expert witness report. I had just come out of graduate school where everything that I wrote, every paper had to be documented and footnoted with a source to the nth degree. And when I turned in my expert report to my defense attorney client, he said, "Pat, this is not the way we write expert reports." I said, "Well, tell me, teach me, show me what I should be doing differently." We would rather that you don't find out that you haven't written a great expert report by working with us rather than from a client the way that I did. And fortunately, he allowed me to revise it, and so that we had an appropriate report that was structured the way that it was supposed to be. This is a day in which we will go through the 4 elements of malpractice and how those standards of care help you in your analysis. We'll talk about the difference between the behind-the-scenes review versus if you are retained as an expert, and why it is critical when you get that phone call from the attorney that you know what role that attorney wants you to play. I have heard stories, and I hope it's never happened to you, of an LNC who got a call and wrote a report thinking that they were behind the scenes. And then the attorney said, "That's great. Now I'm going to name you as the expert." Well, no, I didn't plan on being an expert, and I'm not qualified to be an expert. That gets really awkward. And you haven't charged at an expert rate, and now you've put in writing things that are discoverable. So that is a big mess that we want you to have to avoid going through. We will provide you with a set of medical records. This is from a real case that Barbara worked on to give you an opportunity to analyze those records. And we will also focus on checking the literature so that you have standards that you can refer to in analyzing that case. And what you do when you're asked to write that up. This is a hands-on workshop giving you a chance to work on a case, learn, do some more work on the case, and come back with practical skills and confidence, and also networking and meeting the other people who are participating in this program. We have a special super early bird rate for the first 10 people who sign up for this workshop. That discount you can find by going to the link that Barbara will put in the chat, which is http://lnc.tips/analyzing. We'll be giving you the link again at the end. And that is where you can go to sign up, and also the code to put into the shopping cart to get the early bird discount is on that page. Yep, perfect, Barbara, you got it. Do you have another question for me, Barbara?
I sure do. Now, this segment, we're going to talk about the legal implications of the deviations from the standard of care. And once the deviations from the standard of care are identified, how do they actually impact the legal case? And what is the significance for the plaintiff or the defendant?
Great question, because we have to have 4 pieces that all fit together in order for this to be a valid case. And it is easy for an attorney or a clinician to be swayed because one of these factors is huge. Let's start with damages. Let's say you have a person who's catastrophically injured, and the damages are enormous. But if you don't have deviations from the standard of care, those damages can be extremely tempting for the plaintiff attorney, but is not going to result in a successful outcome for the plaintiff. Those kinds of cases I have called damages in search of liability. The more experienced attorneys recognize this factor. They will say, yes, I realize I've got very strong damages, but can you please look to see what they did wrong that will help me in being able to pull this together? Another issue, and by the way, it is lnc.tips in the link. It may look like a capital I for you, but it is LNC. Please go to lnc.tips if you're having trouble with the link. Another issue is you have enormous deviations. The staff did not deliver the care appropriately, but then nothing happened to the plaintiff as a result of that. That's a problem. That's also very appealing to attorneys who say, well, I know that they didn't do what they were supposed to. Can you just please help me by finding out what was the outcome? What made a difference? And when that occurs, you've got big liability, but you have no damages. Another issue, which happens less frequently, is that there is a duty to provide care to the patient. Maybe the attending physician corralled one of his buddies in the hallway and said, you know, Mr. Neurologist, I've got a 53-year-old patient who's complaining about the worst headache of her life. And I'm curious about your thoughts on what test I should order. Well, you're thinking, okay, aneurysm, bleed. And Barbara, if you put that into the chat for everyone, you're sending it to me specifically.
Oh my goodness.
That's why.
So sorry, everyone.
So the consult is a curbside consult. The neurologist never writes a note in the chart, never places an order, never assumes care of the patient. That individual is not named in the suit, maybe not even known because of the circumstances of this discussion. I worked on a case in which a woman went in an ambulance with her teenage daughter who was having a seizure. And when she got into the ambulance, she told the driver that she was dizzy, and he took the daughter and the mom to the emergency department. She fell in the emergency department and fractured her leg. Well, the attorney wanted to sue the ambulance driver. The patient was the teenage daughter, not the mother. So we discussed this and said, you know, the driver didn't have a duty to the mother. The mother wasn't the patient. And she fell after he drove away. So how can we hold him responsible for what happened in the emergency department? Those are some of the key things to think about, is to make sure when you're talking to attorneys that they are focused on the 4 elements and that you're talking through those breaches, those damages, the causation, which is often what the physician ties together for us as nurses, and that all 4 elements are going to be in place for that to become a strong case for the plaintiff and therefore for the defense. If you're on the defense side, that you're working to defend that case and probe where are the weak areas in the case.
Thank you. At this time, I do want to repeat the link for you. For whatever reason, I don't have access to send out a group link. It's only to the host or to you, Pat. There's nothing that I can send to the group.
Okay, then let me do it.
Okay, so it's http://lnc.tips/analyzing. And we'd love to have you join us on June 5th from 10 to 4:30 for this excellent program. And I know you'll all learn so much.
And could somebody check that link and make sure that that's working and then put in the chat that says, yes, the page is loading? That would be helpful as we continue on.
Pat, can you share an example of a case where uncovering a deviation from the standard of care made a significant difference in the legal outcome?
I worked for 3.5 years on a case that some of you who are present in this call or have heard me talk about this on our podcast, resulted in a roughly $12 million verdict for a woman who had an anoxic brain injury in the delivery room. Big damages. She'll never walk, talk, be able to care for her child. And what we discovered in working on this case for that length of time was that the anesthesiologist gave a top-off dose of an anesthetic drug into the epidural catheter that knocked out this woman's diaphragm. So she went into a respiratory and then a cardiac arrest in the delivery room. Didn't happen immediately. It happened over the course of the time that they were operating on her to do an emergency C-section. Then the anesthesiologist fumbled the resuscitation and thought that she could handle it, and precious minutes got lost as a result of her inability to appropriately intervene. She delayed in intubating. She delayed in calling the code team to come in. She delayed in starting compressions or saying to one of the residents who was helping to sew up this woman's abdomen, "Can you start doing CPR?" She didn't tell anybody in the room there was a crisis. The way that the people in the room found out about it was that her uterus turned bluish, it lost tone, and there wasn't the normal amount of bleeding. So the people staring at her incision or her abdomen and looking at her uterus as they were starting to close her said, "Hey, Mrs. Anesthesiologist, is there a problem here?" And that's when she said, "I lost the airway. The patient stopped breathing." Didn't tell anybody what was going on up to that point. So that was a key case. She had a duty to take care of this patient. She deviated in terms of the administration of anesthesia, monitoring the vital signs, and responding appropriately in the code. Her delays caused the injury, and the damages were huge.
Thank you. Maureen, thank you so much for your compliment about the classes that we have taught together being awesome. So we certainly appreciate that. Before we wrap up, Pat, can you share any final advice for legal nurses when it comes to identifying and handling deviations from the standard of care in medical records?
I'll go back to what I said in the beginning. It's the standard of care is not the most skilled nurse who ever walked the face of the earth. It's tempting, really tempting, because we are perfectionists in this field. We are detail-oriented. It's very tempting to apply that standard of care. We also have the benefit of hindsight. We know what happened. We're working our way backward, sometimes months or years later, to try to reconstruct what happened. We know the terrible outcome. The people taking care of the patient during that time don't know how it's going to end. They don't have the benefit of hindsight. They don't have the ability to say, let's do a do-over. If I had my chance to change the care I delivered, I surely would. That doesn't happen. We also have to maintain our objectivity. When attorneys come to us, they often have a bias. They've done a will for John and Sarah, and now John and Sarah come to them and say, "We have a son we're taking care of at home. He has a brain injury. Can you help us with the letters of administration so that we can be his guardian?" And the attorney, as happened to one of my clients just recently, says, "Well, why does your son have a brain injury?" And then the story comes out. It turns out it's a huge damages case with some significant liability questions. Now, sometimes the attorney comes to us and says, "I know this is a great case, and I am sure that you're going to find merit to this." And famous last words, Barbara has heard this like I have, "Don't worry, it'll never go to trial. They're going to settle this case." Doesn't always happen that way. We have to maintain our objectivity and to be able to take a position in guiding the attorney behind the scenes or being an expert and being able to defend our position when we are cross-examined. So anything that could affect us in terms of a conflict of interest or bias, you have to let go. You have a responsible role in the legal system. It costs more money than you could possibly imagine to put a case through 3 to 5 years of expenses. Any number that you think is too high, I can guarantee you an attorney's firm has spent more than that. These are complex cases, and they rely on you to give them guidance right in the beginning. There's an expression that says a bad case doesn't get any better.
So true. Well, at this time, we do have a few minutes to accept a few questions. So if you'd like to put them in the chat, we can try to address them. I'd imagine that people are probably typing right now.
And Krista is mentioning a lot of Pitocin pushing. Providers are harassing the nurses all day long. Yes, that's one of the stresses of working in the OB area. Inadequate staffing is certainly a factor, Nancy, and there may be institutional liability for not providing enough staff or enough qualified staff to manage a unit. That's something that often is explored in discovery.
Well, I don't see any questions yet. Maybe people are still typing. Oh, here's a question. Krista is saying, I have a huge conflict of interest question. I'm a travel nurse and I'm considering an assignment.
Well, Krista, you're saying you're naming the name of the hospital. And can you tell us by putting in the chat what is the nature of the conflict? In other words, are you being asked to review a case and the hospital is part of that same healthcare system where you're working? That would be what I'm asking you to clarify. And while you're doing that, there's another question, charting by exception. Oh, yes, one of my favorite concepts. I ended up writing a book that went into 4 editions on nursing documentation, and charting by exception is by far a time saver and yet can leave huge holes in a medical record trying to reconstruct the patient's condition at a specific time. Because in theory, if their lungs were clear to auscultation in all 4 lobes, and that's the factor that would allow you to check off normal, that means that the nurse has done that assessment. Then something comes up where there's a question about the respiratory assessment. The nurse is not able to clearly defend their actions if they haven't documented the abnormalities. The defense attorneys love charting by exception as a general rule because it gives them some room to maneuver. The plaintiff attorneys try to pin the nurses down on charting by exception. And of course, nobody remembers 2, 3, 4 years later when their deposition is being taken what they actually saw or did because they charted by exception. So it's a huge landmine. Barbara, other questions that we have time to address?
Gina has asked, what else is another scholarly source besides the ANA Code of Ethics when it comes to citing deviations?
Well, the ANA Code of Ethics has a pretty narrow scope in terms of discussing the nurse's responsibility to be a patient advocate. Depending upon the clinical issue, there may be literature that will refer to the Code of Ethics and weave it in. You know, for example, for nurses who work in the operating room, if a physician comes in who is a surgeon and is clearly impaired and wants to operate on the patient, as has been known to happen, by the way, then the nurse's responsibility to intervene, to report that physician before the physician can pick up the scalpel and start surgery, will be reflected in the code of ethics, but there may also be in the operating room nursing standards the responsibilities to perform in a responsible and ethical way in situations where patient safety is at risk. I would think that that would be a way that you could tie it in. The code of ethics has been revised a few times, but essentially the wording has been consistent for decades. And the concepts apply for sure when we're looking at nursing responsibilities to the patient to be a patient advocate and to protect them from people who could injure them.
There are a variety of other sources as well, which includes your ANA Scope and Standards of Practice, the State Nurse Practice Acts, and nursing specialty organizations. You can obtain their scope and standards, take a look at their core curriculum. These are just a few of many examples that we're sharing with you. Well, we are so happy to have all of you here today. And I want to thank Pat for her expertise and encouraging you, the audience, to attend our upcoming event, our workshop, which will do a deeper hands-on learning dive into a case. Attorneys need answers that they can use. And this is where we, as legal nurse consultants, can help them. They don't have time for vague opinions or missed details. If you're not confident about analyzing a case outside of your clinical nursing specialty, or you're unsure how or where to do your research, you're not alone. Many legal nurse consultants face the same challenges, especially with nursing malpractice cases. So on June 5, 2025, from 10 a.m. till 4:30 p.m., Pat and I are offering this hands-on workshop which is designed to fix that and answer your questions. And many of you have additional questions that I know that we can't get to today. We encourage you to join us then, where we will have designated Q&A sessions. You will work with experienced instructors on this day on June 5 to review a real case, identify the key issues, learn how to find reliable sources that support your opinions. You'll know how to ask the right questions when the attorney makes that first phone call to you. So you'll get the information of what you need right from the start. You'll get clear examples of how to tell if a case has merit before you spend hours going down the wrong path. If your clinical background does not match the case facts, we are going to show you how to close the gap with smart research and strong analysis. You'll leave with practical tools that you'll be able to apply right away. And these tools are going to help you write better reports, make you sound more credible, and keep attorneys coming back with more cases to you. This isn't theory. It's the kind of focused real-world practice that helps you do better work, build trust with your clients, and grow your business. So Pat mentioned earlier that the first 10 people to register are going to get the early bird discount. So register at http://lnc.tips/analyzing. And we would love to see you there, and we'd love to answer your questions. Thank you so much for coming today.
Barbara and I love to talk about this subject, as you can tell. There are so many stories of incidents that are stuck in my brain from the 25 years that I testified in nursing malpractice cases. Again, there are multiple opportunities for injuries, and we see, just as legal nurse consultants, we see a small portion of the incidents that have resulted in injuries. Somebody in the family has become suspicious and has sought out an attorney. The attorney has decided to take that case because of the damages and the liability out of the hundreds of cases that they get contacted about. Out of every 100 cases, they take only 4 or 5. All the rest are never making it through the screening process. We have a critical role as legal nurse consultants in helping attorneys, particularly plaintiff attorneys, carefully use their resources. It's incredibly expensive to take a medical malpractice case, and you've got a vital role in helping them by analyzing the records. We appreciate you being here, and we would love to have you with us on June 5th from 10 a.m. until 4:30 Eastern to get some hands-on experience in looking at a real case. See you then.
See you then.